When a normal sinus rhythm degenerates into ventricular tachycardia, the synchronized pumping of the heart stops, and the muscle writhes in electrical chaos. As ventricular rates exceed 150 beats per minute, diastolic filling time virtually disappears. With the chambers unable to fill, cardiac output drops sharply, and systemic blood pressure plummets. This acute loss of systemic perfusion immediately cuts off oxygen to the brain, presenting clinically as pre-syncope, total syncope, and impending cardiac arrest. Managing this emergency requires a strict two-step clinical protocol. The immediate intervention is dictated entirely by the patient's acute hemodynamics, while long-term management relies on mapping the underlying architecture of the myocardium. The immediate clinical danger of ventricular tachycardia lies in the catastrophic mechanical failure of the cardiac pump it induces. This ECG shows sustained ventricular tachycardia, a rapid rate of 120 to 220 beats per minute, and wide QRS complexes greater than 0.14 seconds. Confirming this, we see atrioventricular dissociation with random P waves and fusion beats merging normal atrial impulses with the ventricular signal. Pinpointing these precise electrocardiographic markers is critical. It prevents clinicians from misclassifying a lethal ventricular arrhythmia as a manageable supraventricular tachycardia with aberrant conduction. Once the rhythm is identified, the master treatment algorithm branches into two distinct paths based entirely on hemodynamic stability. The unstable criteria include profound hypotension or signs of acute pulmonary edema, indicating imminent cardiovascular collapse. If the patient is pulseless, the condition is treated identically to ventricular fibrillation. This requires an immediate, unsynchronized biphasic shock of 150 to 200 joules, followed directly by 2 minutes of continuous CPR. If the patient is hemodynamically unstable but still maintains a palpable pulse, the protocol shifts to synchronized direct current electrical cardioversion, administered using a short-acting anesthetic. In the presence of hemodynamic collapse, electrical intervention supersedes all pharmacological options to immediately restore systemic perfusion. We now return to the algorithm for patients presenting with a stable pathway, where blood pressure and cardiac output are temporarily maintained. This physiological stability affords clinicians the time to trial intravenous pharmacotherapy to terminate the rhythm. The primary acute options include intravenous beta blockers, such as esmolol, or class 1 antiarrhythmics like lidocaine, administered as a 50 to 100 mg bolus. Alternatively, amiodarone can be infused at 900 to 1200 mg over 24 hours to achieve rhythm control. While pharmacotherapy buys crucial time, this pathway hinges entirely on the patient's continuous ability to maintain their own cardiac output during treatment. There is a specific clinical caveat. Ventricular tachycardia frequently presents as a reperfusion phenomenon during an acute ST elevation myocardial infarction. In this ischemic setting, stabilizing the myocardium requires strictly maintaining serum potassium levels above 4.5 millimoles per liter. If the tachycardia becomes incessant and refractory to early interventions, the protocol dictates the intravenous administration of 8 millimoles of magnesium infused over 15 minutes. When active ischemia drives the abnormal electrophysiology, optimizing metabolic and electrolyte balances is as critical as administering targeted antiarrhythmic medications. Long-term prognosis depends on structural heart disease. In the structurally normal heart, ventricular tachycardia typically originates from a single focal point in the right ventricular outflow tract. The definitive treatment is catheter ablation. By neutralizing this focal point, clinicians achieve a 90% success rate. In the absence of structural disease, the tachycardia is a localized electrical anomaly that can be permanently cured rather than chronically managed. Survivors with structural abnormalities, such as post-infarction scarring, carry a massive and persistent risk of sudden cardiac death. This SCDEFT trial chart corrects a major assumption, demonstrating that antiarrhythmic drugs like amiodarone fail to improve mortality over a placebo for these specific patients. Consequently, the mandatory first-line therapy for secondary prevention is the implantable cardioverter defibrillator. The ICD continuously monitors the cardiac cycle. Upon detecting a lethal rhythm, it automatically initiates overdrive pacing, or discharges an internal 30-joule shock to terminate the arrhythmia immediately. Pharmacotherapy cannot repair scarred myocardial tissue. For the structurally diseased heart, Only a permanent implantable device effectively neutralizes the persistent threat of sudden death.